If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle. Welcome back to the Driven Athlete Podcast. Quick, short one about herniated discs. All right. It's very interesting. Herniated discs are super common, right? Neck pain and back pain, and very rarely less common thoracic spine, right? The middle back of your spine. So if somebody has back pain and they have pain down their leg, right? A big trash can term is called sciatica. Trash can being like it collects a lot of things, as in like the sciatic nerve or that region of the nerve is irritated and sending signals, right? Danger signals, right? A fire alarm signal, as in like there's something wrong, right? And radiculopathy would be referred pain from a nerve root level that then can cause, at a more extreme rate, specific muscle weakness like foot drop, right? Or in the neck, like thumb and hand weakness. And then sensory changes, as in like decreased light touch sensation. Like it feels deadened, right? So muscle weakness and sensory diminished symptoms. That would be more like radiculopathy. But referred pain and like is a little different. And that's just pain, non-specific pain in the glute or down the leg. And I like using the term low back pain, but with referred pain. It's just referred from your low back versus sciatica. I think it's more accurate. All right. Sciatica is just like that area is, your nerve is involved, right? But referred pain is more, I just think, accurate. So with that being said, people can have back pain or neck pain with referred pain down the arm, the trap, the shoulder blade, like the middle part of your shoulder blade, down your forearm, hand, numbness, tingling, pins, needles, pain down your glute, down the hamstring region, the back part of your thigh, the groin. And when somebody comes in with back tightness and pain down the groin, the back of the leg, the glute, or down their arm, shoulder blade, right, we have to rule out, it's not just, I'm not thinking hamstring, right? Unless they randomly increased their sprints and hamstring curl regimen of their sports or activity. It's usually, very commonly, our first thought or head hypothesis goes to back pain, back issues with referred nerve pain. All right. And this referred nerve pain are just signals saying that there's a fire alarm signaling that there's a danger involved, right? And it's usually referred from the low back. Okay. And herniated discs can be a cause of that, but we're finding often it's not the case. It's just interesting, right? So hear me out. Herniated discs are very common. Okay. Study was showing 70% of people over the age of 43 have some kind of abnormality or disc involvement in their back. 70% of people over the age of 43, but you don't see 70% of people getting back surgeries or discectomies or just with back pain, right? It's not that much comparative, right? Otherwise, you would think if there's a structural abnormality that it directly equates to pain and the severity of pain, which is not true. There's plenty of people that have a good-looking image on their MRI or X-ray with like no herniated discs and the disc levels are normal, but they have severe referred pain, radiating pain down their leg and back pain, spasms and stuff. And then you have people who have not a great-looking image and their back is pretty jacked up. Like there's intervertebral disc herniations, narrowing of disc space, degenerative disc disease, degenerative joint changes, arthritic changes, foraminal space narrowing, which is stenosis, ligamentum flavum inflammation, right? Ligamentous inflammation, arthritic inflammation, all that stuff, pushing on the nerve root, right? And they have no pain. It doesn't make any sense. There's a disconnect between symptoms and the structure, right? So structural abnormality and structural changes don't correlate and connect with the actual symptoms, functionality, or prognosis of how someone feels. And these studies just kind of support that. So with that being said, if somebody has a herniated disc, like there's no reason to jump off a cliff. A lot of people have herniated discs. I probably have herniated discs. I'm sure I do, right? I have intermittent back pain that gets tight occasionally. I played football in college and volleyball, played 2 sports. Like, dude, we've done some stuff. I'm sure there's some abnormalities evident, but that doesn't determine or correlate and dictate symptoms or pain, especially for prognosis and future direction, right? So it's just very interesting. All right. So with herniated discs, systematic review of 1,100 patients on a lumbar MRI between the ages of 20 to 70 years old, 87% of people have evidence of disc involvement, herniations, bulges, whatever. But you don't see 87% of people hobbling around with back spasms, referred pain, and then requiring discectomies, right? Systematic review of 3,100 patients on a lumbar MRI, 37% of people at the age of 20 had some evidence of disc degeneration, narrowing of the disc space, herniated, bulging, the abnormalities, right? Degenerative changes of the disc. 37% of 20-year-olds. But you don't see 37% of 20-year-olds in hobbling back pain, right? Like spasms and referred pain down their back. 96% of people by the age of 80 had evidence of disc degeneration. 86%, but you don't see 80. Like not every old person has back pain, right? I mean, 86 is 80 years old is up there, right? But not all of them have back pain, right? And then 70% of people over the age of 43 have evidence of abnormalities in the spine. Arthritic changes, narrowing of the disc space, narrowing of the foraminal openings, right? And then ligamentous involvement and inflammation. But not all of them have referred back pain or back pain at all. So there's a disconnect between disc herniations or abnormalities and actual pain, right? And if that's the case, is the disc actually the source and generation of pain? These studies would suggest no. It can be, and I don't hate surgery. And if that was the case, then why not just get a discectomy right now? Problem solved, right? Just fix the structure and your pain will be resolved, right? That's not always the case. And surgeons are really good at determining that and making decisions for sure. I don't hate surgery. Sometimes it's necessary, right? And I'll tell a story of a young patient that I had, young being like early, mid-20s. But it's not always the case. Surgery might not be the route. There's plenty of people that have had surgery, 2 surgeries, 3 surgeries, and they're still in back pain. But we fixed everything structurally. Structurally, at this point, everything's good. So then why are they still in pain? The disc might not be the source of pain, right? So then what is, right? I mean, nerves. You have nerves everywhere, totally, right? You have muscles, ligaments, tendons, bones, the joints, joint capsules, discs, but you also have nerves. And nerves take the longest of anything to heal. And they take a long time, and they're very resentful. They have a great memory, and they're very sensitive, and they take a long time to heal, right? But they do heal, and they're the ones that send signals, danger signals, whether perceived of tissue damage or real tissue damage, perceived or real. They're still going to send signals. They don't know the difference, and they're going to be received, right? And then a decision is made that pain is present, right? But if we can affect those nerves, then it'll decrease the pain, right? Like nerves are at a very hypervigilant intensification state of sending signals like a car radio on full blast. We just got to turn the car radio volume down. And the best way to do that for these nerves is blood flow and movement. Movement to acclimate nerves to movement again so they can be more resilient and less hypervigilant and hypersensitive. And then also blood flow to deliver nutrients and oxygen because they need to heal, and they need oxygen and nutrients just like any other tissue to help heal and re-regulate and create a new resting regulation tone of signaling, in addition to the receptors that receive those danger signals. So with all that being said, like herniated discs are very common. And with that being said, why not just get a discectomy? There's plenty of people that have pain linger, even though the structure has been fixed. So then why does it still hurt? Then why the disc might not have been in the generation of pain, the pain generator. Or they have pain on the other side of their leg or the other part of their neck or down their other arm, whatever, right? And then getting another surgery to do it again. I'm like, yo, put the knife down. Like it might not be the route, right? Let's do some, if we know that the pain generator is coming from a different source, then we can do a different approach to maybe create a benefit and improvement, right? Might not be the route to go. Everything's not so patho-anatomical. Patho meaning like pathology, anatomical meaning structure. There's not everything is a problem with the structure. Like that's the pain generator, not the case. At least that's what the research is finding. And researchers, not me. I'm just relaying information that the research and empirical evidence is finding. That's what they're suggesting, right? So with that being said, what maybe can we do to improve pain if the structure is not the problem, right? Story about, sometimes it is though, and like I said, I want to tell a story. There's a 26-year-old patient I had back in Houston several years ago, and he had referred nerve pain down his leg with foot drop, right? His foot wasn't strong, right? Like he lost motor function because of the nerve communication, right? There's different pathways of entrapment or of things that can get involved at the communication all the way from the spinal cord through the back, down the leg and the glute to your leg and your foot to innervate for motor and sensory. So if somebody's having sensory changes and motor dysfunction, like they're weaker in their foot, like foot drop, of course we're thinking, there's nerve involvement, totally, right? But what source and how can we intervene, right? It can be improved without surgery, totally. There's plenty of cases and evidence to support improvement with that without surgery. I don't hate surgery by any means, right? It's totally necessary, right? Sometimes, but not always. And I wouldn't jump into it, at least me humbly in my own opinion. Of course, I'm biased because I'm a physical therapist, but like I would never just be like, surgery, problem solved, right? Like, let's dive into the matter and pursue something and investigate different routes, right? Or just at least have a conversation and multiple opinions and whatever. But anyway, so this kid individually, like he had specific referred nerve pain at a specific myotomal and dermatomal pattern, like muscle weakness and sensory change weakness and diminished sensory. And it wasn't getting better. The three things that we think about if it's a true herniated disc that's causing the pain generation and the dysfunction. Does it hurt with sneezing, coughing, and Valsalva movements, like pressure? Sneezing, coughing, and pushing. Does it hurt in the morning? And then you have hard neurosigns. Hard, unrelenting morning pain is what I should say. Like nothing really makes it feel better. And then hard neurosigns, hard neurological signs, as in weakness in a certain pattern of muscles that are from that specific nerve root. And then also sensory changes that's called a dermatome that innervates a skin area region from a specific nerve root in your low back. If you have hard neurosigns in those myotomal and dermatomal patterns, unrelenting pain that doesn't get better in the morning, and then also pain with Valsalva, right? And you're younger, as in like below the age of 38, right, or 35, that's when I'm like, maybe this is actually a true disc. Let's refer out, man. Let's investigate another option, right? And of course, with anybody, and he did, and he had surgery and he felt better. I was like, dude, perfect. I'm happy. High five, right? Sometimes we need that. But always not the case. And of course, if we do conservative route first and it's not getting better, then guess what? We'll go get another opinion and do an MRI again, right? Or just go that route. We'll get an MRI and check it out, get a surgeon's opinion, totally, right? But what if it works and you don't need surgery? We just avoided it and you feel better, right? That's where people get hung up on the imaging and they say, but I still have the herniated disc. That doesn't equal success or failure. According to the research, there's plenty of people that have herniated discs present and they're totally fine. That's not always the case of like success, failure, herniated discs, pain, structural abnormalities, dysfunction. That's not always the case. Just some food for thought, something to think about, and something we chat with our patients about. And there is definitely a different route you could go if you want. And if it's not getting better, then we'll definitely pursue another route and refer out, totally, right? But what if it is getting better? Then we just avoid surgery. Awesome, right? That's a win, right? Anyway, so that's just a little food for thought. Take that for what you want. I'm always open to suggestions in the comments, questions, concerns, conflicting opinions, and I like to have a discussion, conversation. So don't hesitate to reach out, and we'll catch y'all next time.